So, health home tiers. The best practice for allocating the appropriate tier. This has been, I don't want to call it a hot topic. It's been a blazing topic, right, for many of us that have been doing this work. Okay, so I just want to preface it by saying that we understand that this is something that many of us are wanting to get understanding of and get clarity on. So I just want you to know that we are doing this. We're going to do this topic today with you in mind, right? We want to make sure that you're having information that is going to be beneficial to you. Okay, so I just as the topic says, it's the best practice for allocating the appropriate tier. Okay. Now, I know that many of us live in a world of black and white. As we know, the health home program is a subjective program because we are working with clients based on their needs. However, when it comes to the guidance of tiers, there is a specific formula or specific allocation or specific information that indicates what tier indicates what information would indicate what a tier is. Okay, so just an FYI that today what we are going to be going over is the best practices for allocating that appropriate tier. So we're going to cover all of these topics, the definition of each tier designation. Some of this is going to be in a nutshell, just basic, gosh, why can't I find my words today? It's going to be a review for many of you. There it is. There's the word. Good gracious, Aunt. Get it together. Okay, here we go. We're going to talk about the review of the tiers 1, 2, and 3, how to assign the appropriate tier designation utilizing best practice methods. There's that phrase again, documentation standard for monthly tier encounters, and then the big one, the movement between tiers. All right, that is our subject today. That is our mode of operation today. This is what we are going to cover in this process. Again, any questions that you have, please put them in the chat, or not in the chat, in the Q&A pane. We are going to handle those once this presentation is completed. We don't have a lot of slides, but we have enough slides, and then we'll have plenty of time to talk about it, okay? So the next screen, let's talk about that 3-tier process. So as we all know, for many of us that have been a part of this program, we know that there are 3 tiers, right? We have the tier 1, which is the G9148 billable billing code, which indicates the initial HAP. We have that tier 2, G9149, which is the intensive health home care coordination, and tier 3, the G9150 low-level health home care coordination. All right, we're going to define each of these in their entirety as we go through the process. And so we're going to start with tier 1. Let's just get into it. The outreach, engagement, and health action plan development. Now, you all are going to get a copy of these slides at the end of the day. All right, but I want you to know that everything that we are talking about today is taken strictly from the contract. So this is the contractual language that is driving this presentation. But I just want you to understand that the contract is the contract to keep us in compliance, which outlines what the expectations of the program are. But when we talk about the training aspect of it, which is what we're going to be talking about today, these are the best practices to ensure that the contractual requirements are met. Okay, so just remember that. Well, it doesn't say that specifically in the contract. The contract has language that is indicating what we want to do or what we should be doing, what we're required to do. These best practice methods that we're going to talk about today is going to ensure that those contractual obligations are met. Okay, so when we talk about the tier 1 outreach, engagement, and health action plan development, it's that initial HAP. It occurs once in a lifetime, and it occurs in person. All right, so again, this is an in-person visit that we must make. So I know we talk about face-to-face and the conflation between face-to-face now with telehealth and things like that. The tier 1 must be in person, because if we want to make sure that we're there in their presence to complete that HAP. Okay, so that is what that tier 1 is. Pretty self-explanatory. You can meet anywhere, wherever that's convenient for the client. Again, this is a client-centered program. We all know that. So whatever is going to be convenient and conducive for that client's needs, that's where we want to be meeting, right? So that's tier 1 in a nutshell, once in a lifetime. And I just want to say this real quickly. Let's just say that you're getting a person that was with another CCO and they transfer to another to another CCO or to another MCO, and they get reassigned to another care coordinator. And you decide that you're going to do another HAP with that client because maybe you don't know what their HAP dates are. That person would not be considered a tier 1 at that time because they have already opted into the program. You can still do the assessments or whatnot, but then you would have to allocate whether or not they're going to be a tier 2 or a tier 3, but they cannot be billed a tier 1 again. All right. which let's take us straight over to tier two. So tier two is an intensive health home care coordination, all right? And this verbiage is taken directly, as I stated before, from the IMC contract. So typically, and I had to make sure that I italicize, bold, and even underline typically. Typically, intensive health home care coordination includes one face-to-face visit with the enrollee every month, in which a qualified health home service is provided. Now, let's talk about that real quick, because as a care coordinator, having done this job before, I assumed that if I saw you face to face, regardless of what I had you allocated as for a tier, that meant that you would be a tier two because I saw you face to face. That's not what it is. Okay. This is for the face-to-face is implied based on the fact, or it is implemented based on the fact that if a person is designated as a tier two, it is indicating that they have complex needs, which means that if they have complex needs, we would want to see them face-to-face. That is a client that we would want to go into their home. We want to go see them face-to-face in a place of their choice to just see how they're doing. As we like to say, put eyes on them. Okay. So just want to put that out there, right? The method of visit or the method of encountering the client does not drive the tier. It is the acuity of the client, the complexity or the lack thereof of the client that drives the tier, the tier allocation. Now, we know about exceptions, right? There are exceptions to the monthly face-to-face visit that can be approved by the contractor, the MCO, or the leads. If the health home services provided during the month accomplishes coordinating and addressing the client's HAP goals, health, and social determinant of health needs, okay? So those exception processes, and we know all of us that were here for several years prior to the public health emergency ending, we know that we had that tier two exception due to COVID-19 protocol or due to COVID-19 or public health emergency, whatever the lingo that you used, right? But once the public health emergency ended and there was consideration taken for those individuals whom did not want to be seen face-to-face due to the fact that they were either immunocompromised, or also due to the fact that they just were not comfortable seeing people face to face, there was still the opportunity for, yes, as a care coordinator, you want to stress or attempt to make a face-to-face visit with them using options such as social distancing, meeting in places where you don't have to be in a closed space or whatnot. But if they still are resistant to that, then you can incorporate that tier two exception process, which many of your leads and your supervisors should be familiar with, okay? So again, if you're unfamiliar about what that tier two exception looks like in this day and age, post-public health emergency, please make sure that you reach out to your respective supervisors and or your leads to get clarification on what those requirements are, because they do have the autonomy in incorporating that. Again, as far as to how those would look, all right? But you do have the opportunity to utilize that tier two exception for those individuals. But typically, the tier two is for complex members or members that have complex needs and are denoted based on complex needs. And then the best practice or the protocol would be, if possible, to see them in person or face-to-face. But when you can't see them face-to-face for whatever reason specified by the client, not for our convenience as care coordinators, but specified by the client, the member, then that's when we want to incorporate the tier two exception process protocol. So here are some components of a tier two assignment. So these are just some of the things people may ask, well, what does a tier two look like? How will I know if an individual is tier two? Again, there are best practices or whatnot, but the reality of this is what we're going to talk about, okay? We have a highest tier level of health home care coordination services once a client opts into the health home program. So again, this is what a tier two is, but it can incorporate one or more of the elements of the 6 defined health home services by implementing any of the following. Again, this is contractual language, okay? Clinical, functional, and resource use screens include screens for depression, alcohol or substance use, disorder, functional impairment, and pain appropriate to the age and risk profile of the individual. Enrollee assessments to determine readiness for self-management and to promote self-management skills to improve functional or health status or prevent or slow declines in functioning, and fostering communication between the providers of care, again, that care coordination piece, including the treating primary care provider, medical specialist, personal care providers, and others, and entities authorizing behavioral health and long-term services and supports. And then there are some other components as well, moving on to the next slide, the promoting of optimal clinical outcomes, including a description of how to progress towards outcomes will be measured throughout that health action plan. So again, the HAP is very important in indicating what type of tier or what tier designation that your client is at. This health education and coaching designed to assist beneficiaries to increase self-management and skills and improve their health outcomes, and the use of peer supports and support groups and self-care programs to increase the enrollees' knowledge about their healthcare conditions and improved adherence to prescribed treatment. So I read all that to say this. What does a tier two look like? Again, this is the contractual language, but if I gave you layman's terms of what a tier two person or tier two clientele would look like, it's the individual who may be struggling with their healthcare outcomes, the individual that has a hard time interpreting their medications, a hard time adhering to medication to their medication regimen. They may go to the ER a lot. In fact, they're in the ER a lot. They're hospitalized a lot. They may be dealing with a severe disease, or maybe just had a major injury that's going to require rehabilitation, in which they're going to need a lot of assistance and care. Again, you as the care coordinator who is on the ground, you're going to be able to see that and make the determination. And for the record, as care coordinators, you have the ability to be able to do that, because as care coordinators, and you're the one that's seeing them, not your supervisor, not the MCOs, not the state. You are the ones that are there in the home with the client. You're hearing their story, you're seeing their condition, or you've talked to them over the phone via the tier two exception process. You're talking to their doctors. You're looking at those ED reports or those point click care alerts that you're receiving on a regular basis. So you know what's going on. And if you have a lot of things going on with that client, okay, then that's a tier two designation in that regard. That's the best practice for a tier two designation, particularly if it is happening over an extended and a consistent amount of time. All right. And I just want to re-emphasize what we said before for the Q&A, that we're going to just get through the presentation first, okay? And then we are going to do the Q&A after. I promise you there will be plenty of times for questions and answers. We just want to make sure that we're able to get through everything so that we can answer everybody's questions and give everybody's question the due diligence that it deserves, okay? So just an FYI, I'm not ignoring anyone. We're just putting it in the Q&A, all right? So let's transition over to the tier three, which is a lower level of health home care coordination. And this occurs when the client and the health home care coordinator identify that the client has achieved a sustainable level of progress toward meeting self-directed goals. The goals have evolved and are aimed at maintaining and sustaining behaviors, and the client doesn't necessarily need that hands-on assistance with goal maintenance. Many of us on this call are familiar with the clients that we've worked with in the past that require, and this is not a knock on them, but they do require some hand-holding to get them from point A to point B to point C. And that's totally fine. We have those individuals that we work with, right? And those are our most vulnerable and most needy clients, and it's okay. But you do have some of those clients that are like, Anthony, I don't need you like that. I don't need you all up in my business like that. I just need you to direct me to where I need to go, and I can take it from there. And for those types of individuals, those are the indicators for the most part of your tier three clientele, provided that they're actually following through on what they say that they don't need help with. So again, you have to make sure that you're obviously looking at what your clients are doing and making sure that they are following through on the things that they need to do. And for those guys that are doing that and gals that are doing that with goal maintenance and whatnot, and are doing the things that they need to do, looks like you have all the indicators for tier three, okay? And of course, this is at the client's request. Again, I just kind of talked about that. The client doesn't want intensive services. They would prefer a phone call, and maybe they want periodic contact, okay? Maybe they don't want to be seen every month. Maybe they're like, they want to be seen every other month. Remember, this is a client driven program. So I know what many of you may be saying, well, if they want contact every other month, then what about my billable for the month that they don't want contact in? So then in those months, again, is the documentation aspect of it, that piece of it, to make sure that at the very beginning that we're telling the story that, hey, this particular client does not, this is what the client wants to be seen as, okay? Now, we want to make sure that we specify to them that it is a monthly contact, that we want to make sure that we're able to see them monthly, or at least speak with them on a monthly basis to just see how they're doing and to make sure we check up on their goals and action steps and perform those types of duties. But if the client is adamant, again, it is client choice. We make sure that we document to that, okay? So we're going to move over to the next slide. Let's talk about assigning tiers. The best practice, okay, again, best practice is going to be interwoven throughout all of this, all right? Remember, gave you the contract language, and now we're going to talk about the best practice to make sure that we can adhere to the contract language. So when you are assigning a client to a tier, please consider the following: their acuity, the level of severity of the client's conditions or illnesses. You know, there's that PRISM again, you can access PRISM for a snapshot of the client's conditions and utilization. Their PAM score, what is their PAM level? 1, 2, 3, or 4? Do they have any elevated screenings, any elevated screenings that is related to conditions. Let's just say that you've seen in PRISM that this person is dealing with mental health conditions, and you see that their PHQ-9 is at like a 20 or 25 or whatnot, okay? And you're seeing that there's a link between what they've been diagnosed with and what the screenings are saying, and the screenings are elevated. Then those are just some earmarks to where you could say, okay, look, this individual could very well be a more complex individual, or maybe less complex because they're not scoring that high and they don't have those conditions that require intensive needs and constant monitoring, if you will. And then, of course, continuing with the assigning tiers, okay, you want to consider current treatments, physical or psychological, as we just talked about briefly. The client's disposition, when you talk with them, does it seem as if they're coherent? Does it seem like that they understand? Do they appear to understand the conditions of how to handle them? Are they actively participating in their treatments? Are they struggling with their conditions and their treatments? Caregiver input. Does the client have a caregiver or support group that provides insight into the individual's health status and the maintenance of their conditions? And then, of course, a support system. Does the client have a support system? And if not, and the client's conditions are severe, this can determine as well which tier level would be assigned, because they could need someone to come along and be with them on their journey to help them manage everything. Now, again, these are some of the best practice aspects that one can utilize. Remember, as a care coordinator, your role is to assign a tier based on the client's complexity or of conditions or the lack thereof, all right? So we're not interested in the billable rate from a care coordinator standpoint. Again, as we talked about earlier, this is about, from the standpoint of you, the care coordinator, you're going to be concerned with the acuity. The acuity, as we just talked about, the complexity of the member's conditions or the lack thereof. That's what's going to drive your interaction. We leave the billables to the billable experts, okay? Now, documentation. Did I say documentation? Monthly encounters with clients should be documented in accordance with their accurate tier designation. So the documentation should include what type of encounter it was. Okay, obviously, if it was in person, physically, or face-to-face, we know we have telehealth out there for some of our organizations or some of our leads and their CCOs, they're utilizing that. Telephonic, utilizing that tier 2 exception that we talked about, or telephonic for a tier 3 encounter. Which of the 6 health home services did you provide, and how did you provide it? One of the things that I've always trained to is this, is that we always want to indicate the how, right? Your progress notes are the portal through which anyone that is going to look into that file is going to be able to see the work that you've done. So people are like, well, duh, Anthony, I've heard this before. But particularly when it comes to tiers, because as we talked about earlier, what you document, what you implement in these files is going to be the foundation for what is billed by your billable department at your organization. Again, you're there to talk about, or to worry about, or focus on, if you will, the acuity of the member, but the documentation that you put into your file should indicate exactly what you did. So I gave you a little example. So if you did provided comprehensive care management, so we'll just say Anthony provided comprehensive care management by reviewing the client's goals and action steps. The client is still working on their goals that are currently set and will continue to move forward with those. Care coordinator will continue to provide supports in that regard. Now, I gave you my synopsis of how I would have documented to that, okay? But at the end of the day, we just don't want to put in, hey, provided care coordination or referral to home health and community services, or whatever it is that we're putting down. Whenever we put something down, elaborate briefly in a sentence or two of what you're doing. That gives the meat, if you will, or the foundation or the context to what you're providing. So it makes it easier to justify what it is that you are setting the member as, for example, as their tier designation, all right? We want to make sure we're documenting any collateral follow-up that has taken place or will occur with providers listed on the client's consent form, and any next planned follow-up. Now, some of this is best practice. Now, some of this, we've heard of this before. This is best practice. You probably read about this or saw this whenever you went through your one-day state training. However, we just want to make sure that we're reiterating it here, because the documentation part is huge. If it's not documented, we know it didn't happen, but I'll take it a step further. If you don't document it, you really cheat the experience for the standpoint of really talking about what you did for the client. You're cheating the client's voice from the standpoint. It could cheat the client's voice from being able to actually have what is happening for them, or what is occurring for them actually being articulated, and And you're cheating yourself if you do that, because now you're not really talking about all the great work that you're actually doing. You're leaving a lot of meat on the bone, if you will, or off the meat on the bone as far as to what it is that you've been doing. So just please make sure that you're talking about it in a concise way, but yet in a thorough way, if that makes sense. Let's focus now on the movement between tiers. Okay, and I think I moved too fast. All right, there we go. Movement between tiers. This has been a big one, right? So the health home tier system was not designed to have clients changing tiers. And this is, you may be familiar with this slide. We just took it verbatim from our list of the modules that we've done. But the health home tier system was not designed to have clients changing tiers month to month based solely on the number or types of contacts. We've talked about that before. The movement to a tier or between tiers is based on the engagement of the client and or their caregivers, activity that is going on within that health action plan, provision of at least one of the 6 qualifying health home services, and frequency of contacts, whether it be face-to-face visits, phone calls, referral, or care coordination. So what this looks like is this, in a nutshell is this, and we talked about this before. A face-to-face doesn't necessarily, or an in-person or face-to-face does not necessarily indicate that that person is a tier 2. What does indicate that that person is a tier 2 is going to be the engagement or the lack thereof, the type of activity that is happening, the type of goals and action steps that you're working on, the client's conditions. All of those things are going to be indicated, as we talked about before, in regards to what tier you would build. Now, typically, there's that word again. After a tier 1 activity of establishing the HAP is completed, a client could move to a tier 2 or will move to a tier 2. But in some cases, based on the preference of the client, I want to reiterate, based on the preference of the client and their individual needs, they may move directly from a tier 1 to a tier 3. Again, you as care coordinators, you are trusted to use your ability to access this, to assess, the situation, and to be able to allocate the tier based on the client's preferences and needs, and also their conditions that they may or may not have, okay? Or that they do have. The tier will not change from month to month. Again, the tier does not change from month to month. I'm talking about care coordinators now. We're talking about at the grassroots levels. You as care coordinators will not change the tier from month to month between tier 2 and tier 3. But it will change when the client or their caregiver consistently demonstrates an intensive or low-level health home need. And when that happens, and when you start to sense that the client is moving from the tier that they're in and that they may need to move to another tier, the first thing you want to do is make sure that you have a conversation with that client and let them know about that, okay? Because this is a client-driven program. This program is going to be based on the client themselves being able to make that determination of where they are in their care. And if that client's determination of where they are is in collaboration or is in collaboration with what you are seeing, they don't need a lot of help. They don't need a lot of assistance. They've been a tier 2, but they've improved so much. They're better. They've met their goals and their action steps. And they're like, we can cut these to, we can move to a tier 3, or how you would have that conversation to a lower level of care, to where now it could just be a phone call a month and they're okay with that. Then that's when you would make that indication. Or vice versa. They may have been a tier 3, but they had a sentinel event and they're needing a lot of help. And they're in a situation that maybe they've never been in before, to where they're like, now I used to be self-sufficient and now I'm needing a lot of help just navigating life right now. I need all the help I can get. And then that will be the time to have the conversation about moving to a tier 2 and with that client, and to let them know that by going to a tier 2, we're going to be able to provide you with more supports and to be able to just be there for you for all of the needs that you may have, and to help get you connected to those services or to those needs that you may have. Okay. And I kind of gave you an example of what a tier 2, moving from tier 2 to tier 3. Okay. So then here's just some examples, right? The client's patient activation measure has stabilized over the past 4-month period with an optimal level of activation. HAP goals have been achieved. The client's prison risk score is under 1 for 8 months, and the client's PAM level is at least at a 3. Again, these are best practices. These are earmarks. There is no, absolutely no, well, this is what you want to look at, but these are just some things that you can look at to help make those determinations. A client has met their goals and is actively sustaining self-management activities, and the client has no new HAP goals to set or current issues to achieve requiring a higher level of coordination, and has achieved and demonstrated self-management skills. Goals may be modified or new goals added in collaboration by the client and the care coordinator, or the client can just request a lower level of care coordination. Anthony, we don't need to see each other every month, bro. We can just, if you call me, that's good enough. So again, those types of things. Again, it is client driven, as we all know. Now moving from Tier 3 to Tier 2, an adverse health condition or new diagnosis resulting in increased emergency department use, hospital admissions, readmissions, escalation or exasperation of a behavioral health or social concern, or increased primary care or specialist visits. So the client expresses a desire to set a new HAP goal, and environmental, psychosocial, or life events changes trigger a need for more intensive health home services. And you can include in those social determinants of health. Those will always play a role. You can never separate the person from the conditions in which they live. Those also can play a role in also indicating what tier that individual would be at as well. So I'd initially come up with a page for scenarios, but when I looked at the scenarios, it's like we've already talked about it. But you know what? Since I've already came up with them and I worked really hard on these, let's go ahead and do them anyway. Okay. So I'm just going to bring up a couple of scenarios and I'm going to put them on the screen here. Can y'all see that screen with the scenarios? Or not? You can? Okay. I'm going to read them out. Okay. And again, you can put this will be interactive. You can actually put this in the chat because again, this is not there's really no right or wrong answer. Okay, I'm just going to ask you what tier you would put it at for scenario 1, scenario 2, and scenario 3, and we're going to move on and we'll go from there. Okay, so here is your first scenario, care coordinators and staff. A client or a member has opted into the program with a PAM level 2 and multiple chronic conditions. During their current and subsequent encounters, the care coordinator notices that the client is still struggling with adhering to their medical treatments and attending appointments, as well as completing their goals and action steps. Based on what you've heard, just based on what you've heard right here, what tier would you designate this client or member as? You can just put it in the chat real quick. I know we have a lot of folks that are here, but just put it in the chat. It's totally fine. We're not gonna, want to make it a little bit interactive today. Boom, 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 boom. Yep, everybody's doing it. Yeah. Excellent. You guys keep responding to that one. I'm going to move on to the second one for the sake of time because I want to give enough time for Q&A. Scenario number 2. Care coordinator has been providing services to a client or a member and for several months. Now, during this time, the care coordinator notices that the client has began adhering to their medication regimen, and they're starting to attend those appointments with various providers. Furthermore, the care coordinator notices an increase in the completion of goals and action steps. The care coordinator also notices that as they interact more with the client, remember that they need less and less assistance with scheduling appointments and taking medications. This is going to be a yes or no question. Should this client member be considered for tier 3 lower level of designation? Oh, I saw that when we talk about it. Yes. Thank you, somebody. Who did that? Who said that? Chandra. Yes. When we talk about it, yes. I like that. I'm not that everybody else is wrong, but I like the fact that she put that caveat in there because that is really important. We want to make sure that we're making that decision with the client's blessing or with their consent. Okay. So absolutely. Everybody gave the right answer. I just like that part of remembering is based on having that discussion with the client as well. So thank you for that. Scenario number 3, last scenario. Care coordinator has allocated a client or a member as tier 3. And after several months, that care coordinator notices an increase in emergency department visits and inpatient stays. Now, while completing assessments, the care coordinator notices that the client is still maintaining a high PAM level. They're still maintaining a PAM level 4 in this case. However, the client's conditions require more intensive care coordination. What tier level could this client be assigned as after having a conversation with them? Tier 2, or would you keep them at tier 3? Survey says. I saw that. Y'all are going so fast, but I love what we're seeing. Miriam says tier 2 with rehab update goals. Yes. Yes. Interweave that happened to that. Excellent. Those are my 3 scenarios. And in a nutshell, while this is subjective and there's no fluid process, again, what you all just did right there, what you exhibited, what you showed was based on your knowledge of what tiers are, based on what you know, objective versus subjective, right? Exactly. Based on what you know, this is how you were able to incorporate or to indicate what tier you would have a conversation what conversation that you would have with that individual regarding their tier or regarding their the assignment that you would have for their tier in interacting with that particular client. Okay. So I hope that that was a little bit helpful. Again, it's not necessarily a fluid process. It's very subjective, but at the end of the day, the best practices, having the earmarks of looking at certain aspects of the client's care, that will really help assist you with being able to make these determinations. And of course, as Chandra said, you want to make sure that you're having that conversation with the client, because we don't change tiers for clients based on our own convenience, right? We do it for the benefit of the client themselves, to accurately depict what their acuity is. So thank you for participating with that with me. Now, let's talk about common billing errors. Okay. Now, you as care coordinators, many of you don't do the billables. Okay. This is more for your allied staff and for your supervisors. Okay. So again, this is why your documentation is so important. Okay. Now, of course, billing for more than one encounter in a month, that doesn't apply to you, because many of you, as you know, once you document in your respective systems or platforms that you're trained on, and you select that billable for the month, that billable carries the day, no matter what else you do. As long as you provide one billable, that's, or one tier billable, one of those 6 health home services, and you submit what that tier is, that's a wrap. That's what you have, right? So you don't have to worry about that aspect of it. Again, some of the other factors of demographic information is not complete. The dates of service are missing. Again, we just talked about this, moving the client from tier 2 to tier 3 with no due to no contact in the month. Billing tier 2 without sufficient documentation. We're going to talk about that again. Your documentation is going to carry the day. Or billing tier 2 without documentation. Man, okay, so somebody just took that literally happened by itself. I did not have this on the timer. My screen just flipped. So if I get up here and run out of here, that means I got ghosts in the house. Y'all finish the webinar without me, because that was weird. That doesn't happen often. Okay, so back to what I was saying. Billing tier 2 without documentation of face-to-face. In a nutshell, what that means is this, is that the documentation is not carrying today, okay? Or accidentally billing the wrong tier or submitting billing late, okay? These are all things that you as care coordinators, many of you don't have a hand in submitting the billing, at least most of you probably don't, in submitting the billing to the lead, and who subsequently, processes it. But you just want to make sure that if you take nothing from this slide, the best practice aspect of it for you, my wonderful care coordinators that are out there, you want to make sure that your documentation and your interaction with that client indicates what tier they have been assigned for that particular, well, not for that particular month, but what tier they are assigned as, and the work that you've done or what interactions you've had with that client to justify the services that you provided. And before we move to questions, I just want to say this, that in many situations, we think that a tier 2 every month is going to be that person that is going to always be at the emergency room, or they're going to always have, some type of something's going on, right? We called it back in the day, them being on fire or being very, very complex, if you will. But the reality is this, you could have tier 2 individuals that, yes, they do have complex needs. And yes, they have those months to where they have a lot of things going on, but the month they may have a month where there's not a lot going on. And there's not a lot to document in regards to, oh, I did all this, I went and did that, I made this call, I made that call, or whatnot. You did your tier 2 due diligence with them. You provided some of the 6 health home services, one or more of the 6 health home services, and it was all done in one visit. Doesn't seem like a lot, but you did a lot. That person doesn't move to a tier 3 just because they didn't have a lot going on in 1 month. They move to a tier 3 or from a tier 3 to a tier 2 based on change in their needs or change in their conditions, or by their own preference of wanting to move to another tier after you've had a conversation with them. So I just want to make sure I put that out there as well, that a lack of complexity or a lack of running around for a client in a month does not mean that they're not still a tier 2 acuity. Everyone can have a quiet month, as we all know in our lives. We can have that month where it's like, it's not a lot going on, but still doesn't mean that we don't have needs or complex needs or whatnot, okay? So I just want to make sure I put that out there as well.